This presentation will review the use of psychotherapeutic medications in the treatment of major depressive disorder in children and adolescents. I do not have any relevant financial disclosures. The purpose of this presentation is to review the scientific literature regarding medications for preschool children and youth with major depressive disorder. This review will serve as a starting point for the update of the 2018 and 2019 Florida Best Practice Psychotherapeutic Medication Guidelines for children and adolescents with MDD. The guidelines provide recommendations for psychotherapeutic medication prescribing based on the latest evidence, clinical consensus, and in this case, we're specifically addressing depression. Understanding the general principles of practice, comprehensive assessments, and treatments of psychosocial assessments and treatment with psychosocial interventions are extremely important and included in the guidelines, but will not be the primary focus of this presentation. This presentation acknowledges those factors, but will focus on reviewing the latest evidence, mainly since our last review being published in 2019 on the use of these medications in the treatment of major depressive disorder in kids. So let's begin with an overview of major depressive disorder in children under the age of 6. And what do we really know? Well, we know that depressive disorders are already present in preschool age and increase markedly during adolescence. They then become one of the most prevalent global mental health problems. As with a lot of disorders, the presence of preschool depression is a risk factor and predicts major depressive disorder later in childhood and early adolescence. So therefore, we know that intervening at a preschool age may avert the chronic and more relapsing course of depression. As we know in a lot of disorders, intervening earlier helps prevent that. So the manifestation of preschool depression can have potential long-lasting implications and may lead to more chronic functional impairment and poorer outcomes, especially across certain developmental domains. But we know it still remains poorly studied, and that no antidepressant has been demonstrated consistent positive results. And in this case, it should be preschool kids and not prepubertal children. Fluoxetine there's been a smattering of evidence of fluoxetine in 8 studies, a couple case series and 2 quasi-experimental designs, but very small numbers and none looking at depression. There's evidence examining sertraline and escitalopram as well, including one randomized controlled trial by Potter looking at the use of sertraline in ASD in children with autism spectrum disorder. But basically, there are no studies examining the use of antidepressants in preschool children with depression. So as we'll discuss, you'll see the recommendations remain the same, right? That if the depression in this age group is severe, or there's continued poor response to psychosocial interventions alone, one should potentially consider a combination of treatment with fluoxetine and concurrent psychosocial treatment. We do not recommend the use of medications alone without psychosocial treatment. So think about it. If the depression is severe, not moderate or not moderate to severe, and the psychosocial interventions resulted in suboptimal responses, then possibly in 4 to 5 year olds, the use of fluoxetine could be considered. So moving on to children and adolescents, and specifically, let's look at medications used to treat major depressive disorder in this age group. Based on the data available to us since our last review, the overall approach to use of antidepressants has really not changed. The risk-benefit balance for fluoxetine in youth depression remains favorable, while it's less clear for other SSRIs in general. And deliberate monitoring And with all these medicines, as you know, for the efficacy as well as adverse effects, and in particular, suicide-related events and other side effects like behavioral activation is really important. So SSRIs are indicated for children and adolescents with moderate to severe major depressive disorder, accompanied by moderate to severe functional impairment. However, these medications are generally not prescribed or used for patients who have subsyndromal depressive symptoms or even mild depressive disorders. The bottom line is currently there remain only two antidepressants that are FDA approved for the use and the treatment of MDD in this population. As mentioned, fluoxetine has the most robust evidence, and escitalopram is also approved for adolescents 12 to 17 years of age. So moving on to review the evidence for each of the medications briefly, there is no new major evidence to report on the use of fluoxetine. Fluoxetine improves clinician-rated depressive symptoms, response, and remission among adolescents with MDD when compared to placebo. For other populations, including children with MDD or adolescents and children with mixed depression diagnosis, the evidence for fluoxetine versus placebo is a little less robust. So for children and adolescents with acute depressive disorders, the first-line pharmacotherapy is generally fluoxetine. There's more consistent, high-quality evidence for the efficacy of fluoxetine than other antidepressants. Fluoxetine has also been demonstrated in other studies to be effective for relapse prevention among children and adolescents. And here you see a summary. Remember, the focus is on the strength of the evidence, so generally we'll be discussing or reporting on randomized controlled trials and not either case series or even open trials as well. But a couple of other studies should be highlighted. The TAD study, as you just saw, is probably the largest and highest quality acute phase randomized placebo-controlled trial of any antidepressant for adolescent depression. And we've discussed this in the past, and it still remains a classic benchmark for the use of fluoxetine in this age group. Three other studies just worth reviewing. One is the ADAPT trial, where individuals that were resistant to treatment to one and who hadn't really responded to one antidepressant were switched to others or combined with cognitive behavioral therapy, and demonstrated that 50 to 60% of these adolescents who hadn't responded to one antidepressant did respond to a second, and that the continuation studies showed that up to 60% of the participants appear to have remitted as well. The ADAPT trial was a randomized controlled trial of CBT in adolescents with MDD that were being treated with SSRIs. This study was important because it included severely impaired teens who were pre-treated with an acute brief psychotherapeutic intervention and then randomly assigned to two different treatment groups, medications alone, or fluoxetine alone or fluoxetine and CBT, right? And it demonstrated how about 50% of the participants responded acutely, but over the longer term interventions, about 80% or just over 80% appeared to have demonstrated a positive response. And then just briefly, this was not a randomized controlled trial, but this was the TASA study, which was important because it included individuals that were displayed suicidal behaviors, and that these individuals were typically excluded from most randomized controlled trials. And it demonstrated that that the response rate at the end of the acute phase was about 70%, not only on depression, but also on the use on the presentation of suicidal behaviors. Now, moving on to escitalopram, right? The benefit of escitalopram for children and adolescents with depressive disorders is a little more modest based upon 2 randomized trials. In 2009, the FDA approved escitalopram for the treatment of adolescent depression for children, for teens 12 to 17-year-olds. However, this approval was generally not consistent with the standard of 2 positive randomized controlled trials. One RCT, the Emsley study, demonstrated that that the patients with escitalopram revealed greater improvement compared to placebo, right? And then the Wagner study found that improvement of symptoms of depression with escitalopram and placebo was comparable. However, later looking at a subgroup analysis in the teens, they found that the improvement of depressive symptoms was greater with the medication than with escitalopram alone. So a meta-analysis of the 2 trials found that there was a trend for a greater rate of response or remission with escitalopram compared with placebo. Sertraline, and you'll see here the main studies, Wagner and colleagues reported a pooled analysis of 2 similar multi-center 10-week randomized trials where they compared sertraline, a mean average daily dose of about 130 milligrams per day with placebo. And the response rate, which was measured by a reduction of baseline symptoms of greater 40%, occurred in more patients who were treated with sertraline compared to placebo. But other studies have not replicated these findings. Citalopram is, as you know, is a racemic mixture of both escitalopram and R-citalopram. Citalopram may be beneficial for children and adolescents with depressive disorders, but the results across randomized trials are inconsistent. One RCT of citalopram showed a positive outcome. That's that Wagner study on the first row. But one large European study did not. The rest of the literature on citalopram for pediatric depression consists of open label trials and retrospective studies. Let's look at now about venlafaxine and desvenlafaxine. So as you can see, venlafaxine may provide a small benefit for the initial treatment of adolescents with MDD, that is in the acute phase, right? And then since 2018, there's been a couple of studies that have examined the use of desvenlafaxine in this population. And these randomized trials indicate that desvenlafaxine is not efficacious in the treatment of MDD. In the Atkinson study, children and adolescents were randomly assigned to 8-week treatment of desvenlafaxine with a lower dose, 20, 30, and 35 milligrams per day, based on their baseline weight, and higher doses of desvenlafaxine, right, with the same dosing, 25 milligrams, 35 milligrams, or 50 milligrams per day, sorry, a little bit higher dosing, versus placebo. But improvement in all 3 groups was comparable. In the other trial, with children with major depressive disorder, they were also assigned to 8-week treatments of desvenlafaxine at either 25 milligrams, 35 milligrams, or 50 milligrams per day, again, based on their weight, or fluoxetine 20 milligrams, or placebo. And the response was comparable in the patients who received desvenlafaxine or placebo, whereas the response occurred in more patients who received fluoxetine than placebo. Duloxetine. And the two bottom rows are the continuation studies of the same two Emsley and Atkinson studies, but two randomized trials of duloxetine in children and adolescents with MDD, one with fixed and one with flexible dosing, and both using fluoxetine and placebo comparators, have been published. Both found that the benefit of duloxetine and placebo was comparable. However, the trials also found that fluoxetine was not superior to placebo. And given that multiple randomized trials have demonstrated that fluoxetine has demonstrated to be efficacious for youth with MDD, the two trials looking at duloxetine are considered failed or uninformative trials. Bupropion, there is no new data. There are certainly no new randomized controlled trials on the use of bupropion in youth with major depressive disorder. So the evidence base remains very modest for this population, and specifically these are mixed populations, right? For example, one study included an 8-week observational study in 24 adolescents with attention deficit hyperactivity disorder plus major depressive disorder or persistent depressive disorder, dysthymic disorder at the time, right? And they demonstrated that the depressive symptoms improved in 88% of those individuals. But again, these are all open trials and there are no randomized controlled trials, so that the evidence supporting the use of bupropion in this population is very modest at best. Vilazodone. So these are new studies that are available since our last update. There are two randomized trials indicate that vilazodone is not efficacious for pediatric major depressive disorder. In the Durgam study, they conducted an 8-week trial with adolescents, 12 to 17, who were randomized either to a fixed dose of 15 or 30 milligrams per day or placebo. Improvement for all three groups was comparable. In the other study, in the Findling study in 2020, which was another 8-week trial, over 400 youth ages 7 to 17 years of age were randomly assigned to flexibly dosed vilazodone, either 15 to 30 milligrams per day, or fluoxetine 20 milligrams, or placebo. And again, improvement in all three groups was comparable. So neither demonstrated benefit over placebo. This study was published very recently on vortioxetine, which is an antidepressant with multimodal activity and effects across a range of different neurotransmitter. It is a serotonin receptor antagonist, a serotonin partial agonist, and an inhibitor of the serotonin transporter. Vortioxetine has demonstrated efficacy on par with most other antidepressants in adults and has been established as having benefits for cognitive symptoms in depression, and the adult literature is generally well studied. In this study, patients in all groups showed a reduction in baseline their depression rating scores by the end of the study, but there was no difference between the combined doses of the medication versus placebo, so that the primary endpoint was not met, thereby rendering the study as negative. We've mentioned in the past, there's been a smattering of antidepressant randomized controlled trials over the years, none recently, as you would imagine, and they have not demonstrated benefit of antidepressants for this population. Including a variety of others. Mirtazapine, a pooled analysis of 2 trials, found that mirtazapine in doses ranging from 15 to 45 milligrams per day provided no advantage over placebo. fluvoxamine, which does not have an FDA indication for major depressive disorder. The evidence is on the efficacy in this population is lacking. And then paroxetine, the randomized trials found no benefit. If you remember the controversies with paroxetine over the years, that the original results of one trial were published way back in 2001 and reported that, quote, paroxetine was generally well tolerated and effective for major depression in adolescents. Subsequent critiques of the original trial led to the release of the unpublished data and a reanalysis to look at several flaws. And specifically to look at the way the selective outcome analysis were reported. The original protocol specified that two primary outcomes. One was the change in the total HAM-D score, the Hamilton Depression Score, and the proportion of responders. Then had 6 secondary outcomes, and there was found no statistically significant differences for any of them. But before and after breaking the blind, several new outcomes were added to the list of outcomes, and the 2001 results focus on the statistically significant results from the outcomes that had not been pre-specified, right? So because of this, there were obviously several changes in the oversight and how we perform these analyses. But basically, paroxetine is not typically recommended for use in this population, both because of the efficacy and as well as the tolerability of potential adverse effects. So there you have it. There's been a few new randomized controlled trials, but the literature remains basically unchanged in support of which medications to use in this population. A brief review about treatment emergent suicidality. Well, again, the literature hasn't really changed. As you know, in 2004, the FDA approved at that time called the black box warning for this class of medication for children, adolescents, and young adults, 24 years and younger. The studies subsequent to that have utilized the Columbia Suicide Severity Rating Scales to specifically look at treatment emergent suicidality. And that generally the research finding revealed similar rates of suicidal events in active treatment comparator groups when utilized in those randomized controlled trials and placebos, with none of the trials really statistically separating from placebo. So there appears to be a slightly increased rate, a risk of suicidal thoughts and behaviors, but not suicide deaths among a small group of children and adolescents who are treated with antidepressant medication when compared with placebo. But the evidence is kind of inadequate to conclusively establish a clear association. The FDA continues with the box warning label regarding the increased risk of suicidality in this population, thus basically requiring the clinicians to discuss the warning with the patient and the family. So when considering the use of antidepressants in children and adolescents, the risk of antidepressant-related suicidality must be weighed against the benefits of treatment and the long-term risk of suicide and untreated depression in this population. And so when considering this risk-benefit balance, the consensus of most psychiatrists is that the benefits of antidepressant therapy generally outweigh the risk. And that children, as we've discussed previously, and you all know, that children and adolescents who are treated with antidepressants should start on low doses and be closely monitored for increasing or changes in suicidal thoughts or behaviors. So most of the studies I've used, as you've heard, have focused on acute treatment and some on continuation of treatment, specifically fluoxetine, right? And what do we know about continuation and maintenance treatment? Well, the data and the recommendations remain the same, right? That children and adolescents with major depressive disorder who remit with pharmacotherapy should continue on the same regimen for at least another 9 to 12 months after that improvement. And why? Because we know that relapse frequently occurs in those patients who stop their antidepressants before that period of time. And what are some situations where maintenance pharmacotherapy should go beyond 9 to 12 months? Well, this is essentially consistent with our existing guidelines when the presenting depressive episode includes either psychotic features, when there's moderate to severe suicidal behavior and or ideation, when the functional impairment remains moderate to severe, when there's treatment resistance, when there's been a duration of depressive symptoms greater than or equal to 2 years, and when there's been an unsuccessful prior attempt to taper the antidepressants. We also know that depressive episodes tend to predict depressive episodes. That is, the more episodes an individual exhibits, the more likely they're going to have recurrences. So when the course of the depressive illness includes 3 or more episodes with major depressive disorder, the maintenance period is much, much longer. Let's talk a little bit about major depressive disorder comorbid with anxiety disorder or disorders, right? So we know that co-occurring anxiety, depression are common in clinical population of children and adolescents. And that children and adolescents with comorbid anxiety and depression tend to have greater symptom severity and less robust medication response compared to those who have either alone. And so that management is based on the principles that the clinicians initially treat the disorder, either the depressive disorder or the comorbid disorder, that creates the greatest distress or impairment. That is, in your hierarchy in working with the patients and families, one establishes what the most impairing or distressing of the disorders. And keep in mind, we're talking about comorbid anxiety disorders and, let's say, depressive disorders, and not major depressive disorders with anxious distress, which we now know that anxiety can be part of the depressive disorder, and that at times there are these artificial comorbidities which may have implications on treatment response and prognosis and outcomes. Or in addition, if a comorbid disorder like a substance use disorder or even an eating disorder such as anorexia nervosa is present, then those disorders may reduce the likelihood of the recovery from depression, and that in certain situations the comorbid disorder maybe should be addressed first, as it may interfere with the recovery from depression. And a brief word on persistent depressive disorder, formerly known as dysthymic disorders. Well, as you saw, there's few studies that are available to inform the use of antidepressants in children and adolescents with persistent depressive disorder. And so in these cases, we consider the use of the same 2 medications of fluoxetine and escitalopram if the persistent depressive disorder is severe enough and creating significant impairment and or distress. There is a smattering of other reports on non-pharmacological interventions such as omega-3 fatty acids and St. John's wort, but at this point in time, there's insufficient evidence to recommend the use of any of those medications. But something that's gotten some discussion and or press is the use of repetitive transcranial magnetic stimulation. There have been 14 studies, which include 8 open trials, that looked at the use of TMS in adolescents. All of those studies really suffered from multiple biases, but they all reported that TMS reduced depression scores in adolescents. But none of the studies included a sham control. So the bottom line is that TMS is promising, right? That the current literature signals that TMS could reduce adolescent depressive symptoms, but with caution, as sham randomized controlled trials are still needed to address whether it is beneficial or not in this treatment-resistant adolescent population. So the bottom line, and again, this is very reductionistic of what our guidelines remain fairly close to what we have now. We can certainly have a discussion as some of the level 4 medications, including bupropion. But we begin with monotherapy, typically with one of the two FDA approved antidepressant medications, with fluoxetine having having a stronger evidence base, so being a 1A recommendation, and followed by the possibility of escitalopram for teenagers only. And one begins monotherapy and increases the dose until one either gets desired improvement of the target symptoms of depression, or there are intolerable side effects. And if that first line medication is not effective at the optimum dose for a long enough period of time, or obviously not tolerated, then one switches to the other one not used. That is, if you start with fluoxetine, then you switch to escitalopram or vice versa, and you continue with monotherapy with that medication. If, again, after treatment for a long enough period of time, or the medication is not tolerated, and you've gone through those 2 iterations, then one should take a step back and really have a review of your diagnosis and consider whether it really is a major depressive disorder, presence of comorbidities, and or consider a consultation with a specialist. And then moving on, when we get to level 4, where the evidence base is much less robust, you may consider switching to the previously used antidepressants to monotherapy with either sertraline, citalopram, venlafaxine, and or combination augmentation strategies. The guidelines will include a review, an updated review for medications, a dosing guide, but for these purposes, we included just the 2 level 1 medications, and there's starting doses and maximum doses for your review. But note that the FDA does not currently provide any dosing guidelines for the treatment of major depressive disorder in children. With for escitalopram, and children and adolescents for sertraline, citalopram, venlafaxine, and bupropion as well. So what are some of the key takeaway points in summary? Well, that antidepressant use is reserved for children and adolescents who meet the criteria for moderate to severe major depressive disorder, and obviously who can be monitored by prescribing clinicians and their families. 2 is that for children and adolescents with moderate to severe MDD where pharmacotherapy is indicated, we suggest treatment with fluoxetine as a first-line treatment. Escitalopram, having a more modest evidence base in adolescents, is approved for teens 12 to 17-year-olds and may be considered an alternative for this age group. 3 is that for depressed youth who do not respond to initial treatment with fluoxetine and escitalopram, as we just discussed in monotherapy and sufficiently appropriate trials, the suggestion is switching if needed, if a medication is still indicated, to either sertraline, citalopram, venlafaxine, or possibly bupropion. And then obviously 4 is for children and adolescents who are treated acutely with antidepressants and remit. The recommendation is that the same regimen be continued for a minimum of 9 months, with the caveat of some exceptions that were presented a little bit earlier for maintenance and continuation for a longer period of time. So we thank you for listening and participating in this presentation on the overview of the use of antidepressant medication in the treatment of major depressive disorder in preschool children, in school-age children, and adolescents. Thank you.